Hello, and welcome to Changes in Pregnancy. Throughout this voiceover today, we're going to talk about the various body systems and what is occurring during pregnancy. Knowing this information will make it much easier to talk about the discomforts that women experience during pregnancy and some of the other considerations. Obviously, within the reproductive system, there is a number of changes that occur. We'll talk about the uterus first. The uterus is going to enlarge from about 2 ounces to around 2.5 pounds at full term. The capacity of the uterus will rise as well from 10 milliliters to around 1,000 milliliters, so a significant increase there. There's some hypertrophy of the myometrial cells that leads to this enlargement. Estrogen will cause the uterine walls to thicken. Most of the enlargement is occurring under the placenta and at the fundus, or that top part of the uterus. Braxton Hicks contractions that may occur help to facilitate blood flow that to support this increased vascularity that is occurring within the uterus. The cervix is the bottom portion of the uterus. So this is a part that we're going to talk about when we discuss dilation and effacement and those terms that occur at delivery. There's a couple things to note with the cervix that are adaptations during pregnancy. A mucus plug is formed that blocks the cervical canal. This acts to prevent bacteria and other substances from traveling upward into the uterus, and it's expelled later in pregnancy as that cervix begins to open up. There is an increase in discharge due to the hyperactive glandular tissue, so women will notice some of the whitish discharge, the thicker discharge. The Goodell sign is a softening of the cervix, while Chadwick sign is a bluish purple discoloration of the cervix. These both can be noted upon examination. Ovaries there is no ovulation during pregnancy. So this is partly because of that progesterone, as we've talked about, and also a hormone called inhibin. Inhibin inhibits ovulation. Corpus luteum will continue to function until around 11 weeks when the placenta takes over. The changes in the vagina are similar to the cervix, are under some of the influence of estrogen in increasing some of these things. So we've got some increasing going on. Secretions are increased. They're thick, white, and acidic, so similar to what we talked about with the cervix, and they help to prevent bacterial infections. However, they are favorable for yeast infections, so women may be more susceptible to yeast infections during pregnancy. Within the breast, there are a number of changes, and these occur both due to estrogen and progesterone. There's an increase in breast size as well as the nodularity due to some glandular hyperplasia and hypertrophy. An increased prominence of the superficial veins of the breasts are also noticeable. The nipples will become more erectile in preparation for breastfeeding, and the areola will darken in pigmentation. There is a hypertrophy of the Montgomery follicles on the surface of the areola, and these will help during breastfeeding following delivery of the infant. Striae may develop on the breasts due to the enlargement. The breast changes are much more dramatic during a first pregnancy than in subsequent pregnancies. Colostrum, which is a rich substance that will be what is given to the infants from the breast for nourishment early on. It may be expressed manually as early as 12 weeks and may leak spontaneously during the last trimester of the pregnancy. So the breastfeeding work starts very, very early on in preparation for the infant. Within the respiratory system, there's a few things that are going to occur. The minute volume, the subcostal angle, and the anterior, posterior diameter, and the chest circumference all increase. And as you can see in this picture, from as far as the diameters, the circumference, and the subcostal angle, You can see why that happens as that uterus enlarges and expands for the pregnancy. The diaphragm is going to lift up a little bit higher as well, and the minute volume needs to increase in the lungs. One thing that occurs is a change in airway resistance under that progesterone influence. This allows for that increase in consumption and the increase in tidal volume and O2 consumption that's going to occur. The tidal volume increases about 30 to 40%, while the O2 consumption overall increases 15 to 20% from 16 to 40 weeks of pregnancy. A couple other things that may occur within the respiratory system is rhinitis and epistaxis under the vascular congestion that's going on. So all of that estrogen that was increasing that vascularity does kind of lead to some respiratory symptoms. There may be some difficulty breathing as that diaphragm has lifted, so the ability for the diaphragm to descend with each inhalation is decreased. So there can be some challenges there and increased shortness of breath. There's a change from abdominal breathing to more thoracic as that everything shifts upward as well. The cardiovascular system also notices several changes. The heart is going to shift upward and kind of rotate, and that's due similar to that respiratory system, just from that pressure and that growth of the uterus kind of shifting the organs. There's many things that increase within the cardiovascular system. The blood volume will increase. That needs to happen to achieve the placental circulation and the other circulations that are occurring. The cardiac output's going to increase to match this. There will be increased flow to organs that have an increased workload. The placenta is a primary example of that. The pulse rate will go up slightly during pregnancy. Femoral venous pressure is increased under the weight of the uterus. Postural hypotension is an increased risk. There's an increased number of erythrocytes and plasma volume. An increased risk for supine hypotension, and we're going to talk about that here shortly and more in class because that is a big risk for pregnant women. And leukocyte production also increases. Some things that are decreased. Blood pressure is decreased. So as we talked about progesterone decreasing some of the resistance in the pulmonary system, it also decreases some of the resistance within the blood vessels. So the blood pressure decreases as a result in normal pregnancy. The plasma albumin level decreases, and there is a decrease in the hemoglobin and hematocrit as a physiologic anemia of pregnancy. This is due, and you can see this on the purple chart here as we look. If you look at the top and you see plasma volume, so you see how that increased pretty significant percentage from non-pregnant values. And then you look at the erythrocyte volume and how that increased, but it didn't increase at as much of a percentage, even with iron supplements. So due to that, there is a result in this physiologic anemia of pregnancy. So iron supplementation can be helpful with that, but there is a tendency towards that anemia during pregnancy. This talks about that supine hypotensive syndrome. So supine hypotensive syndrome occurs due to the weight of the infant on that vena cava. And it makes sense perfectly right here in this picture that you could kind of see where that is, in where the infant is kind of lying right on it. The picture to the left of this slide shows the inferior vena cava and how it's kind of positioned slightly more towards the right side of the maternal body as opposed to the left. So in treating this, we always tip moms to the left, okay? So she can lay on her left side because that puts that right side up, which decreases the pressure on the inferior vena cava the most. Even just putting a rolled up towel under her right hip and tilting her to the left side takes pressure off of that inferior vena cava. This is just another picture of that shows if you put a wedge and you tilt her towards that left side, or if she's flat on her back, what it looks like for those vessels. And we'll discuss, because this clearly, if we're compressing those vessels, it's going to decrease blood flow and decrease blood flow to baby, which can have some negative consequences. So it's very important, especially as pregnancy progresses, to keep this in mind. Gastrointestinal system. So this is where we hear about most of the pregnancy complaints related to things that are occurring during the pregnancy. Nausea and vomiting, so you see that first picture at the top, that can be attributed to the HCG as well as some carbohydrate metabolism changes that are occurring in early pregnancy and is a common concern. Botulism, or you see Homer Simpson there with the increased saliva, is really common, again, during pregnancy, as well as some sensitivity and bleeding gums. So that increased vascularity and those changes that are going on can lead to those bleeding gums and some sensitivity, really noticeable when you're brushing your teeth, but it's still important to really maintain some good oral care during pregnancy. Pressure from the uterus on the intestines and stomach, as well as muscle relaxation, can lead to several things, including the heartburn that you're seeing in the bottom corner of the screen there, and then also the constipation. So we're decreasing gastric emptying and decreasing intestinal mobility due to that progesterone influence. We're also displacing those intestines. We're displacing the stomach as that uterus enlarges. So there is some changes in that. So women may experience that heartburn or constipation due to some of those GI changes, and those could be common concerns and things that we might need to treat or intervene with our patients. Hemorrhoids, we've got that increase in constipation, so increased pressure, increased pushing, and then just increased pressure in general from the pregnancy can increase the risk for those. The last GI consideration that I wanted to talk about today is the gallbladder. So under that progesterone influence, we've got a prolonged emptying time because of that smooth muscle relaxation. So there could be some formation of gallstones that's occurring as that emptying time is prolonged. So increased risk for some gallbladder complications and stones. Additionally, there may be some pruritus as those bile salts are maintained. So women may experience some itchy skin as a result. Within the urinary tract, there are several changes going on. We're going to talk about urinary frequency first. So urinary frequency is primarily just due to the pressure that's occurring. So in the first trimester, as that uterus is first starting to enlarge, there's going to be some pressure on the bladder. And as the uterus enlarges and kind of moves up into the abdominal system, generally women notice a decrease in that frequency through most of the pregnancy. But then in the third trimester, when that the infant kind of drops down into the pelvis in preparation for delivery, the frequency will kind of increase again. As well as this pressure and this weight from a full-term infant is going to limit the drainage of the bladder. So there is a risk for infection as a result of that change. The capacity of the bladder is reduced as well during the third trimester once that infant drops and there has the pressure on it. So the other changes you see here on this slide, so there's an increase in the filtration rate in the kidneys. As an increase in volume is occurring in blood volume, it makes sense that we need to accommodate for that. But in addition, there's some reabsorption that's increased within the renal tubular system. So there is sometimes some glycosuria and other things noticed as a result. So glucose in the urine, although it makes us think of diabetes, in pregnancy may not always be pathogenic, but should be followed up because it could be a result of some normal physiologic changes, or it could be indicative of something such as gestational diabetes. So it is monitored regularly, the glucose in the urine, throughout pregnancy. There are several changes that occur within the skin and the hair in pregnancy. So there's increased pigmentation, and these are in areas that are already hyperpigmented. So you see in that top picture, that linea nigra in that picture, because it's already become darkened, we all have kind of a line there anyway, and it's called the linea alba, but it's darkens during pregnancy. We already talked about the darkening in the areola, so those areas that were already hyperpigmented do increase further in pigmentation. Chlasma, or this mask of pregnancy, and you see that in the middle picture, can occur as some irregular pigmentation on the cheeks, forehead, and nose, and that's just under some of the hormonal influences. Not all women experience that, but it is something that can occur. The bottom picture shows that striae, and just with the rapid enlargement and stretching of the skin, some women will develop this. Again, it's not everybody, but some women will, and they'll notice it possibly on their abdomen. They may notice it as their breasts enlarge, and any other areas that may, with weight gain in general, not related to pregnancy. There's an increase in vascular spider nevi. So those little vascular surface veins that we see, those kind of can increase during pregnancy. In pregnancy, we hear that it makes your hair grow. And really, this is due to not exactly less growth, but the follicles are just more active during pregnancy. So when we're not pregnant, we have a lot of resting follicles, and then we have some active follicles, and that number shifts to more active and fewer resting follicles during pregnancy. And then after delivery, it shifts back. So we increase in resting follicles. So as those number of resting follicles increase, we do see some increase in shedding due to that. The sweat glands also tend to be hyperactive in pregnancy as well, so some sensitivity to sweating and discomforts related to that. The book talks about teeth, and I feel as though maybe the book might word it slightly judgmentally, and just says that it's really all related to oral care, and a good chunk of it is. We do need to make sure that oral care is maintained even through those bleeding and sensitive gums during pregnancy. But there has been some discussion on what occurs during pregnancy to those teeth. Is there some demineralization or not? And I've included a chart here just to a good resource for you if you want to link to it, that talks more about that oral health in pregnancy, because there are a lot of misconceptions in that conversation. There is some relaxation of joints under that relaxin. So some of that waddling gait can occur as that relaxin kind of relaxes all of those pelvic joints in that hip, becomes slightly unstable in that result. The lumbar curve changes, and you can see that very distinctly in that bottom picture as that center of gravity shifts the uterus forward and makes that more distinct. So there can be some backache due to that posture change, and some need to really accommodate and think about that as you're doing activities of daily living. Some paresthesia, so very easy to see as that uterus is enlarging, there could be some pressure on some nerves. So sometimes the sciatic nerve can have some pressure on it, and other nerves that can increase some paresthesia at times during pregnancy. Lastly, and you see this in the top picture, is this diastasis recti. So this is a separation in the rectus abdominal muscle, and it can be severe. It does not occur in all pregnancies. This is something that occurs just to some women. And at times, if it's very severe, it doesn't reverse after pregnancy, so it can be cause to an inability to regain musculature after pregnancy and may need repair. But it is something that can occur as that separation. In the eyes, there is a decrease in intraocular pressure. Again, decreases, that's progesterone. And a thickening of the cornea that can occur during pregnancy. This thickening of the cornea causes some difficulty or uncomfortableness with contact lenses for some women. Most eye doctors will not fit you for contact lenses during pregnancy because of this, because there are some changes in the eyes that are not consistent with what you would be long term. So there may be some uncomfortableness noted. The central nervous system, we see this first one, and it's kind of just a funny example, but we all have probably heard of pregnancy brain. And although there's really no scientific evidence, there is research to support that there is some decreases in memory and concentration and attention span during pregnancy that do seem to resolve themselves by around 6 weeks postpartum. In addition, sleep is decreased, and this is due to a variety of things. Difficulty getting to sleep, uncomfortable needing to change positions frequently, awakening frequently due to position changes or that urinary frequency, and reduced efficacy of sleep. So for a variety of reasons, that sleep can probably further complicate those other considerations. So metabolism. We need to think about where this weight is going and what women should be gaining during pregnancy. So there is an increase in water retention as the water supports the placenta, the amniotic fluid, and the mother's increased blood volume, as well as all those organ enlargements that we discussed. Nutrient metabolism is very important and initially supports maternal stores and then contributes to fetal stores later in pregnancy. So ensuring that we're getting enough nutrients to pass those along to the fetus during pregnancy is really important. Fats absorbed more readily in pregnancy, and that contributes to fetal stores as well as preparing the breast for lactation. In the second trimester, there must be an increase in insulin production. And so any marginal or low function in this area would become apparent in that second trimester. So somebody that maybe is predisposed to type 2 diabetes, in that second trimester, they may not be able to accommodate that increase in insulin production, and that's where we see gestational diabetes developing. We'd also see in somebody that with pre-existing diabetes, they may require more insulin because that insulin need is higher starting in that second trimester. Another need that's increased in pregnancy is iron. Most of iron is stored in the fetal liver, occurs during the third trimester. So in that third trimester, it's important that the mom's getting enough iron to be able to accommodate that fetal storage. That fetal storage is really important as that supports the iron needs of the infant for the first 4 to 6 months. So breast milk does not contain iron. Formula really does not contain a significant amount of iron. Infants really don't start getting iron in their diet until they start adding other foods, and they're not physiologically ready for those until around 6 months. And so it's really important they get enough of that to store and support their needs for those first 4 to 6 months of life. The other things you'll see on this slide relate to some of how much weight you should gain based on BMI for pregnancy. So this is really important. So just in counseling women and educating them, if they have come in and you're admitting them into a room and you note that they're 20 weeks along and they've really already kind of maxed the expected weight gain based on their pre-pregnancy BMI, that would be a conversation that would be really important to have. So knowing how much weight gain, so just, okay, if the BMI is less than 18.5, she should gain 28 to 40 pounds. If it's between 18.5 and 24.9, it's 25 to 35 pounds, and so on. So knowing what they should gain based on those categories. And the other picture here just really shows, again, there's a common misconception that after you give birth that you're going to go right back to your pre-pregnancy weight. And this really shows you why that's not true. So we've got baby, we've got placenta, and we've got the amniotic fluid. Those are going to come out at delivery. But all of the other things, the uterus enlargement takes time to reverse. The breasts, they need to stay enlarged to support breastfeeding. The increased blood flow is going to take time to reverse, or the increased blood volume. Protein and fat storage and increase in body fluids, again, takes some time to reverse. So the weight loss, while some of it does occur at the time of delivery, over time, it takes a little while to get back to that pre-pregnancy weight. The endocrine system has several changes as well. The thyroid increases in size and activity. So you may see an increase in T4 and a decrease in TSH. So women with pre-existing thyroid conditions may need a medication adjustment. Basal metabolic rate increases as a result of some of these things. The parathyroid increases in size and concentration of hormone to match fetal calcium demands. So we want that fetus needs a lot of calcium as it's growing the bones and those other structures. This will return to normal after 35 weeks gestation, so it even returns to normal within the pregnancy time frame. The pituitary gland will increase in size and is responsible for pregnancy occurring, right? Because it did the FSH, LH, it influenced all of those. But during pregnancy, we're going to talk about prolactin. So it increases these levels of prolactin throughout the pregnancy, and that'll be what's responsible for starting lactation afterwards. Oxytocin is responsible for some uterine contractility that's produced by the pituitary gland, and vasopressin regulates blood pressure, and that is also handled by the posterior pituitary gland. So there's some key hormones going on there that are very important. The adrenal gland will secrete more aldosterone during the second trimester. The pancreas is going to meet those insulin needs that we talked about, so when the insulin needs are higher later in the pregnancy. And the hormones in pregnancy were discussed later on. So we talked about HCG, we talked about estrogen and progesterone and relaxin. So those are some of those key hormones and what they're doing during pregnancy that you want to make sure that you're thinking about. So in pregnancy, there's a number of signs listed on this side. So how do you know you're pregnant? That's what this is really looking at. So often these subjective or presumptive signs that we talk about are the things that women are going to call and say, I think I'm pregnant, and they're going to want a pregnancy test done. So these are things like missing a period, fatigue, urinary frequency, nausea, vomiting, breast changes, and then quickening is on here, although that would be something you'd feel later on. Quickening is starting to feel the baby move. But initially that feels kind of like gas. So it fits into these presumptive changes because it could be a number of other things. When you get into the probable, these are things that are objective. These are things we see as providers that we can notice, that we can put into objective terms. So these are probable signs of pregnancy. So those Godel and Chadwick signs that we talked about earlier, the Hagar sign, which is a softening of the isthmus of the uterus, and McDonald sign, which eases the flexing of the uterus against the cervix, along with those other two signs, these are all noted on examination. The abdomen might enlarge. There might be some Braxton Hicks noted. And then the uterine souffle, which is where we kind of hear an increased blood flow and turbulence over the side of the placenta. Ballottement. So ballottement is also noticed on internal exam, and that's just seeing that there is a fetus in there, and it moves against your fingers when you're doing an internal exam. Palpating the fetal outline, so actually using your hands externally on the abdomen, and then the pregnancy tests. So pregnancy tests are kind of sometimes the confusing thing here, because why would they be in objective or probable signs and not diagnostic signs? There are other things that can cause a positive pregnancy test, and the key one that we talk about, and it fits well into this age range, is that a male that may have testicular cancer will have a positive HCG test. So that's really important to note, that it's objective, and there are some other things, and we're going to talk about those when we talk about alterations in pregnancy, that there are other things beyond a normally developing fetus that can cause a pregnancy test to be positive. So it really falls into probable. And then we get into diagnostic. So diagnostic or positive signs of pregnancy. These say, hey, this person is pregnant. The fetal heartbeat. So obtaining a fetal heartbeat, and this can be done with the Doppler, the fetoscope, like we mentioned. And the average fetal heart rate is going to be around 110 to 160. And so that is diagnostic. That tells us, hey, there's something in here for sure. Noting fetal movement by an examiner, somebody that's trained. So a nurse or provider would be a positive sign. And ultrasound visualization. If we see the embryo or the fetus, then we know that it's there. The other thing I wanted to mention on this one is we talk about enlarging the abdomen there under probable. The abdomen fundal height. So we measure from starting at around 20 weeks, the abdominal height should be around the level of the umbilicus. And after that point, we measure from the symphysis pubis to the fundus of the uterus. And we measure that in centimeters. And the centimeters correlate really well with the weeks gestation. So if a woman is 22 weeks, she should measure around 22 centimeters. And this is really important as we track fetal growth. It's a very simple test when they're coming into the office. And we can see, hey, over time, it continues to grow, or hey, there's kind of been a decrease or an excessive amount of growth, and then we can follow up as needed. But it's a really simple test that shows us kind of those trends in fetal growth over time. That is all for this voiceover. I thank you guys for listening.